Welcome to this evening's webinar. My name is Aoife Kerwin and I am the Information Advocacy and Research Officer with MS Ireland. Our organisation are acutely aware of the concerns that our community have in relation to COVID-19, and this evening we are absolutely delighted to be joined by Professor Kingston Mills. Professor Mills is a Professor of Experimental Immunology in the School of Biochemistry and Immunology at Trinity College Dublin, and is the head of the Centre of Study of Immunology at the Trinity Biomedical Sciences Institute. This evening he's going to speak to us about COVID-19, immunology, vaccines, risks for people living with MS. So we do have a chat function on Zoom as well as a Q&A function, so you can send any questions that you have for Professor Mills in through either of those functions, and we'll endeavour to have as many of those questions answered as possible in the time that we have this evening. This webinar is going to be recorded and made available on YouTube afterwards too, so if there's anything that you miss, you should be able to go back and check it. And with that, I am going to hand you over to Professor Mills.
Good afternoon, everybody. You already know who I am. I'm a scientist, not a medic, and I'm in Trinity, and I'm an immunologist, and I work on infectious disease, but also do some work on MS and an animal model for MS. So I know a little bit about that disease as well. I suppose that's why I'm talking to you. I think it's important for me to start with a disclaimer. As I'm not a medic, I can't give you any advice on treatment or drugs, and it's important to note that what I'm saying, both in the slides and the webinar, is strictly for information purposes only, and that you should really talk to your doctor or physician about treatment rather than taking this as advice, which it's not. It's just simply information. Okay, with that out of the way, I'm going to do a brief introduction to COVID and talk about the immunology of it, talk about vaccines, and then come at the end talk about autoimmune diseases such as multiple sclerosis. You're probably aware of some of this. I'm sure if you read the newspapers, you can hardly avoid it. So COVID-19 is a disease caused by a virus called SARS-CoV-2. It emerged late last year in China, probably from bats, and got into the human transmission. It caused a very severe disease of the respiratory tract. It's severe in certain individuals, but in fact, in a lot of people, it's asymptomatic. They don't have any symptoms at all, and the case fatality is around less than 0.5%. It's primarily spread by sneezing and coughing. You see here the droplets. If somebody doesn't have a mask on or they don't cover their mouth and nose when they cough and sneeze, they emit droplets, and somebody else in the vicinity of those droplets breathe in, they'll take them in. That's the primary route of transmission. You can also get it through hand contact because you have sneezed or coughed on your hand, or somebody who's infected, and then it can pass it on in that way. But the primary route is through coughing and sneezing. The risk factors are older people, and I'll come back to this in a minute, older people and those with underlying medical conditions, including obesity, type 2 diabetes, cardiovascular diseases, but autoimmune diseases are not considered to be a risk factor for COVID-19 and for getting the infection. The deaths tend to be from acute inflammation. I'm going to come back to this. The most common symptoms are fever, and strangely also loss of smell and taste have been noted in a significant proportion of individuals, even before they don't present with other symptoms. And obviously a cough is another symptom that's quite common, up to 80% of people. Those are in people who have symptoms. And then the more severe diseases, it's systemic problems. There are other organs such as kidney, heart, liver, and even brain. There's some suggestion that the neurological complications of this disease, and I'll come back to that as well. In Ireland, you're probably aware of this, but I wanted to point out a few things. We had a peak of the infection in late April with around 1,000 cases per day. That went down to around 10 cases on average per day in the middle to the end of June. But as we know now, we're getting increased numbers of cases, around 100 per day in the last week or two. If you look at the death rate in the bottom figure, you can see that it peaked shortly after the peak of the number of cases in early May. And now the number of people dying is very low. 1 to 2 per day on average. If you look on the right, this is the hospital admissions and the numbers in the ICU, and that again peaked early in the disease, and it's now at very low levels. I think there are around 20 people in Ireland currently in hospitals, and I think 10 or so in ICUs. Of course, as the numbers increase over the last few weeks, we will see more people ending up in hospital. But the reason we're not seeing as many as we did at the peak is because the disease is now mainly in a younger population, because these are the people who are contacting it through work and other areas. So the severity of the disease in the individuals that are now infected is a lot lower, and about 50% of them have no symptoms at all. But that doesn't mean they can't transmit it, because asymptomatic transmission is a big issue. So people without symptoms can still transmit the virus. If we look at the case profiles in terms of age, and then the hospitalization and death in terms of age, is a very different profile. If you look on the left, these are the age profile. People in the middle years are the dominant ones. Around 17% of all cases are 25 to 35, and the same for 35 to 40 and 45 to 55. And then it's much lower in the younger and the older. But the number of hospitalizations is much greater in the older population, and the number of deaths is by far the greatest in over 85-year-olds. 45% of all deaths are in over 85s, and 34% in over 75s, and then 14% in over 65. So this is a disease that really affects older people significantly. There are younger individuals that can die from the infection, and most of these have had underlying medical conditions such as asthma, diabetes, obesity, which is not a medical condition, but it's a risk factor for COVID-19. There's very interesting gender differences. More females tend to get infected than males. Not shown in Ireland on the right is that generally more males get severe disease than females. That's the international trend. In Ireland, the trend is a little bit different, and I don't have an explanation for that. But this tends to be more severe disease in males than females, but more females get infected. And that's an interesting difference. A little bit of immunology now to take you into really what I want to talk to you about. And I have to give you some sort of background on what the immune system is to try and explain to you why immune therapies for diseases like MS, whether they are or not an issue. So we get infected with viruses, bacteria, parasitic worms. Parasitic worms are uncommon in Ireland, and fungi such as Candida that cause thrush, for example. Our immune system has innate cells, these natural killer cells, macrophages, and then adaptive cells called T cells and B cells. The B cells make antibodies, and all of these help to protect us against these pathogens. So if we get a self-limiting infection like a common cold, or indeed most of us, if we got SARS-CoV-2, these responses would clear that infection. Now, what can happen in certain individuals that have certain genetic susceptibilities, but also as a result of precipitating factors, which I'll come back with, these responses can turn on themselves. So if the T cells or the antibodies respond to self, this is called loss of tolerance, and that results in tissues being damaged and resulting in autoimmune disease. So this is dysregulated immunity that causes autoimmune disease. But importantly, the same cells that protect us against infections are the ones that cause the damage in autoimmunity. Normally they're regulated, but if they're dysregulated, that's when you get the autoimmune disease. In COVID-19, if we look on the left, the individuals that, the cells that control the infection early on are cells of the innate. The innate immune system is what we have naturally. It's acquired as something we get with time. So naturally we have NK cells. These are cells that kill virus-infected cells. We make a cytokine called interferon, and many of you will be familiar with interferon because it's used as a therapy for MS. But the body makes natural interferons, which are antiviral. So what they do is they make it more difficult for the virus to replicate. They stop the virus from replicating in infected cells. So they're useful antiviral agents against SARS-CoV-2. We also have adaptive cells. We have cytotoxic T cells. These are a type of immune cell which kills cells infected with the virus. Primarily, the cell target for the virus are the epithelial cells in the lung. And these cells can be killed by these cytotoxic T cells. And that helps to reduce the spread of the virus. And also antibodies are made. And what the antibodies do is they neutralize the virus. The virus binds to a receptor called the ACE angiotensin receptor on epithelial cells. And what the antibody does, it stops the virus from binding to the receptor. And if the virus can't get into the cell, it can't divide because it needs the host cell to divide. Therefore, the antibody stops the infection in its tracks by stopping the virus from getting in. So the neutralizing antibodies are very important in preventing reinfection. And I'll come back to that in a minute. Now, this is a very complicated slide. You could ignore most of the center if you don't want to look in detail at it. But I just wanted to draw your attention to the difference between what happens in mild versus severe disease. In mild disease, our immune system deals with it. Natural killer cells and T cells kill the virus-infected cells and they eliminate the pathogen, and there's limited damage. And that's what happens in the vast majority of people. 99% of people will clear the infection. But in severe infection, and this would be a proportion of individuals, especially the older population, where the virus load is very high, the immune response is working overtime to try and eliminate the virus. The result is that we get severe inflammation. And the consequences of that is that lots of these cells are fighting, trying to eliminate the virus. But what they do is they also cause issues like thrombosis, where you get clots forming, and then you can get pulmonary embolisms. Also, the virus can cause problems not just in the lung, but it can disseminate and cause problems in the heart, kidneys, and liver. And even in the brain, there's some evidence that encephalitis occurs, and neurocognitive issues, including dementia-like conditions in very extreme cases with very severe. And the other issue is that these problems can be very prolonged after the virus is cleared in a small proportion of individuals. So it's a very severe disease in certain individuals. Now, in terms of what it is that we really want to see happening, is we want a vaccine, because this is the best bet we have in terms of preventing the second and subsequent waves of infection that we think we're going to get. What we're getting now are small resurgences. It's not really a second wave. A second wave would be much more severe than this if we get it. So we need a vaccine to stop that. And what the vaccine will do is prevent the infection. Luckily, the global pharmaceutical industry and universities around the world are working flat out trying to develop a vaccine. I mean, my lab is involved in this as well. And there are about 150 vaccines at various stages of development. Some in preclinical, this is before they're tested in the clinic. And then there are 3 phases of testing, which I'll come back to. And 19 of these are in phase 1, 12 in phase 2, 3 in phase 3, and 2 have been approved. Although one is in China and 1 is in Russia. They haven't really been properly tested. So you can more or less eliminate those as being approved vaccines because they're not really approved. This comes from the New York Times Coronavirus Vaccine Tracker. The New York Times is a fantastic publication, I have no connection with it, for articles on COVID. And it has this tracker which tracks all the progress of vaccines, and it's a very useful read if anyone's interested. Just to explain to you what we want to do with a vaccine. Normally when somebody gets infected with a virus, they get sick and they'll have disease, and if then they recover, they're immune. And this happens naturally with a common cold, with influenza, but also with COVID-19. People who recover don't get reinfected. There's a bit of debate in this in the literature, but so far the evidence is if someone gets infected, that they recover, they don't get reinfected, so they're immune. Now, obviously, you don't want people to get disease in order to get immune. The better way of doing that is to actually make a vaccine where you induce the same type of response. They don't get disease, but they're immune. And that's the long-term goal of making a vaccine. Now, the longer-term goal is to get what we call herd immunity. And some of you might have heard about this in the media. And there's a lot of misunderstanding about herd immunity. People saying we're building up a level of herd immunity in the community. Well, we're not at the moment. We're a long way off herd immunity. Herd immunity is a threshold that has to be reached where around 70% or more people have to be immune, either through infection previously or through vaccination. And right now, and the big deal about this is that it provides protection for people who are not themselves infected, and especially the vulnerable, the older people, where it's difficult to get an immune response. And it really is important protecting the vulnerable, the older, and the people with underlying medical conditions, because it means the whole community is protected. The issue around herd immunity, this is a slide that shows the numbers of people that have antibodies against the virus in a study in the UK. And the green is London. And as you can see, about 14% of all the individuals that were tested in this survey in London were antibody positive. That means that 14% of the population in London have been infected with SARS-CoV-2. It's much smaller in other regions of the UK, down as low as 2 or 3% or 4 or 5 in other cities or regions. And of course, London has had the most cases in the UK. But that tells us that only 14% is a good number, but only 14% of people have immunity. So clearly we're not going to get herd immunity from infection, even in a city where there's very high levels of infection. So herd immunity, the only way we're going to do this is through a vaccine. So what are we going to do in terms of making a vaccine? There are various approaches. You can take the whole virus, you can inactivate it, and inject it into a person. And that's what we've done to make vaccines against polio and influenza. You can attenuate the virus, that is, weaken it and it's still alive, and that's an MMR type vaccine. Or you can take a bit of the virus, the coat protein, and use what's called an adjuvant and inject it. And that's what we use to make the hepatitis B or the HPV vaccine. So those are all different strategies. But then there are newer strategies, such as taking the nucleic acid for the vaccine and injecting it, or taking the nucleic acid and putting it into what's called a vector. And the most common one that's been used against SARS-CoV-2 is the adenovirus vector. Adenovirus is a virus that causes the common cold, and it's a relatively safe virus when it's attenuated. And a number of groups have put the virus messenger RNA into these vectors. And there are various companies now that have, in various parts of the world, that have all of these vaccines in clinical testing. And as you can see, some of them are tried and tested methods, such as inactivated whole virus vaccine or the adjuvant and protein approach, but others are newer approaches which haven't been tried before. These are the ones that are the front runners right now. The Oxford vaccine and the Moderna vaccine are probably 2 of the front runners, along with a couple of the Chinese ones. What has been happening in terms of developing the vaccine, in terms of the speed, has been unbelievable. Normally it would take 10 years to develop a vaccine to get through the 3 stages of clinical testing and licensure. This is a slide that I took from a Tony Fauci presentation, and what it shows is the speed at which COVID-19 vaccines are developing. It's been condensed down to a year to 18 months by expediting every step of the process and actually building the manufacturing facilities before the vaccine is ready. So if a vaccine is proven to be effective, it will be manufactured very quickly. How does a vaccine work? It's back to the T and B cells that I mentioned already. What we want to do is, when we inject a vaccine, you activate innate cells, then they go to the lymph node primes T and B cells, they go into the circulation, and then they go to the lung. The cytotoxic T cells will kill virus-infected cells. But the most important thing are these neutralizing antibodies that I mentioned earlier. These are made and they stop the virus from infecting. So if we make neutralizing antibodies with a vaccine, it's very likely it will be effective. So that's just a brief summary of how it works. So where are we at? Very recent data in the last 2 or 3 weeks released from the phase 1 and 2 trials of the Oxford vaccine showed very exciting data. All of the volunteers who were vaccinated generated these neutralizing antibodies. This just shows the antibody at baseline, and then after vaccination, you can see all the patients have these neutralizing antibody. And they compare favorably with what happens with a person who has the infection or have recovered. About 90% of people got antibodies after 1 dose of the vaccine and 100% after 2 doses. Again, that's very good news. And there were also T cells induced. There were some small side effects, nothing very serious. Now we're moving on to phase 2 or 3 trials. And these are happening in countries like Brazil, the US, and South Africa, because that's where the peak of the infection is. That's for the Oxford vaccine trials. The Moderna one is happening in the US. And what's happening here is that, tens of thousands of people have been vaccinated, and then they wait to see, some would get the real vaccine, some would get a placebo, and then they look to see who is going to develop COVID-19. And hopefully what would happen is the people that got the placebo, some of those will develop it, and then those that got the real vaccine will not develop it. And then you get to work out the efficacy. And then they would have to go, if it works, for regulatory approval and rollout. Now, so what's the next step? The next steps, if you have a vaccine that works, is to manufacture it and then implement it. And what has been happening is that countries like the US have already been doing deals with the various manufacturers to have their own vaccine ready. Europe is doing the same, and so is the UK. So the UK has done deals with a couple of companies. The US have done deals with Moderna and Pfizer. Europe has done a deal with AstraZeneca for 400 million doses. And Ireland hopefully will be part of that to get the vaccine once if it's ready and if it proves to be effective. We don't know yet that it will. The target populations will first be the healthcare workers, the elderly and the vulnerable. And then eventually the aim will be to immunize the entire population, including infants. So clearly the vaccine has to be safe. We're going to put it into infants. If it's going to put it into anyone, it has to be safe, but in particular into healthy infants. Vaccine hesitancy is an issue. In a recent survey, it was found that 73% of Irish people said they would take the vaccine, but about 15% of people said they wouldn't, and another 13% said they were unsure. So it's not going to be straightforward to persuade everybody to take the vaccine. I hope that these figures will increase from 73% if and when we have a vaccine. So that's the good news on the vaccine. Coming now to what you're probably more interested in hearing about, and that is what's the risks for patients, individuals that have got MS. There should be no increased risk of susceptibility to infection with anybody with an autoimmune disease. There's no evidence for this that I'm aware of. There is a theoretical risk of enhanced inflammation once the person gets infected, because autoimmune diseases by their nature are inflammatory diseases. COVID-19 is an inflammatory disease, and if you put the two together, you have the possibility of enhanced inflammation. But what's more important is obesity. Obesity is a very big risk factor in COVID-19. And that's probably the biggest risk factor that I would be worried about rather than some of the other underlying medical. But obviously type 2 diabetes goes very much hand in hand with obesity, and that's another significant risk factor. I mentioned interferon beta. This is an important drug for treating MS. It's also a very good antiviral agent, and it's anti-inflammatory. And in fact, it's being tested right now as an inhaled therapy for COVID-19. So, I think we can safely say that interferon beta, if anything, is going to be beneficial rather than any issue. Some of the other immunosuppressive therapies, and I'll go through these individually in a second, there is some evidence of increased risk of other infections. We don't know really about COVID-19. But there's also evidence that some of the therapies used to treat autoimmune diseases would be beneficial in limiting the damage during inflammation associated with COVID-19. And in fact, some of the drugs used to treat arthritis have been tested in COVID-19 patients for their ability to quell inflammation. This is a list of some of the, most of the drugs that are currently used. I've given the sort of drug name and the trade name. And all the interferons, there are different versions of the interferon. There's no evidence that they're any increased risk. In fact, they may be beneficial because of their antiviral properties and their anti-inflammatory properties. Copaxone, there's no evidence that there's any particular risk with that either. And then we're getting into some of the drugs that there might be some risk, and that's unsure. Dimethyl fumarate, there is some evidence of increased rare diseases of the brain, as there is with Tysabri. And so these are still a question mark as to whether there will be increased risk. There probably is some risk. Probably, the risks of infections in general are more established with drugs like Gilead and Lemtrada, the CYP1 antagonist directed drugs. And I'll show on the next slide, how these work. And the drug that blocks the T cell activation will reduce people's ability to deal with certain infections, and herpes and other viral infections do increase when people are treated with these drugs. The last one is an interesting, the anti-CD20 antibodies, Ocrevus or rituximab. These are the B-cell therapies, and I'll come to how they work in a second in the next slide. These are interesting because they're very effective in certain MS cohorts, but we don't know yet really whether, sorry, let me go back to that, whether they're going to be an issue in COVID-19. We do know that there's some issues of reactivation of hepatitis B in individuals on these therapies, and it's likely that they will reduce the immune response post-vaccination. So if a vaccine came available, it wouldn't be advisable to be on these drugs at the time of vaccination, because what the B cells do is to make the antibodies that you need to protect you against infection induced by the vaccine. This is all summarized again on the last slide, which attempts to put the immunology of MS on one slide. So we think that in combination with genetic factors, the precipitating events in MS are microbes and damaged cells, which precipitate innate immune responses that then go to the lymph node, the same as I showed you for the vaccine, and generate T cells and B cells, except these are specific for self-antigens, not for viruses. These then go into the circulation and will eventually make it through the CNS, through the blood-brain barrier, into the brain. And in the brain, in particular, these T cells called Th17 cells make inflammatory mediators, cytokines, which damage axons and other inflammatory mediators, causing demyelination and axonal damage. Interestingly, the B cell was never thought to be a major player in MS until recently. And that's why it was a surprise to me and others that the B cell targeted drugs work so well. And it seems like what the B cells are doing in this context is not making antibodies, although they do make antibodies, but actually acting as what we call an antigen presenting cell, activating these Th17 cells. So by taking out the B cell, you're indirectly inhibiting the pathogenic T cell. So where do these drugs act? The first one, Tysabri, acts by stopping the egress of these lymphocytes from the lymph node. So it stops the T cells and the B cells getting from the lymph node into the circulation and eventually into the brain. A very effective drug. Gilenya and the other CYP1 antagonists, these are oral drugs that stop lymphocytes getting across the blood-brain barrier. And if you stop them getting across the blood-brain barrier, they're not able to get into the brain and cause the damage. So again, another effective drug. The B cell drugs, as I mentioned, these are effective because they take out the B cells and they stop the activation of the pathogenic T cells. And then you have the CD52 targeted Campath, which targets this interaction between the B and T cell. And then there are various drugs that target proliferation of this T cell. This T cell needs to divide to make these mediators. And if you stop that cell division, you stop the activation of it, you stop the production of these mediators. And finally, it's not 100% clear how the interferons or Copaxone work, but one of the theories is that they induce natural immune regulatory mechanisms which turn off the pathogenic T cells. So these are perhaps not as effective as some of the other drugs, but they're, in the context of COVID-19, they're certainly the safest. So that's, I think, all I wanted to say, and I'm happy to take questions. I don't know how I see the are you going?
I think we have to swap screens, so I'm happy to just chat to you from here. So we were sent in some questions in advance of this, but certainly if anybody has any more questions, they can put them through. But I could ask.
Yeah, if you want to ask me the questions, I'm happy to try and answer.
Great, wonderful. So one of the questions that we had sent in was, would people living with MS be any more or less likely to be asymptomatic carriers compared to the general population?
I think the short answer to that is no. I mean, there's no evidence why they should be any different. I mean, I think if in terms of the infection with the virus, in my view, there's no evidence that having an autoimmune disease will make you more or less infection to the virus or the replication of the virus. So the answer to that is no, I don't think so. That's not to say there won't be a difference especially in terms of the treatment or lack of it and the outcome of the infection, but not getting infected.
Okay. Another that we have had in is, if a number of vaccines become available, is there a way to understand which might be the most beneficial for people living with MS?
Right, I'd be delighted if there's more than one vaccine that's, I think if we had one, it'd be fantastic. I mean, if I might predict what I think will happen, I think we will see some vaccines that are effective at preventing disease, but don't prevent transmission of the virus. And that would be a second best, but better than nothing. Clearly, what we want is a vaccine that prevents infection. And if we get that, that's the one that we will go for. But, you know, as I tried to explain in one of my slides, one of the issues is that countries have done their own deals with vaccine manufacturers. So, for example, the Moderna vaccine, the US has advance purchased all the vaccine they're going to make in the first 3 months. So no other country will get their hands on that vaccine for 3 months after the US have got the first allocation of. Now, there are lots of European companies making vaccines, so hopefully one of those will be effective, that Irish people can be vaccinated with. But we may not have a choice of a half dozen vaccines to work from. We may have one, if you know, and I think it would be great if we had one that worked effectively and that was available in Ireland.
Okay. Another question we have in here on the Q&A is, can COVID-19 infection lead to MS relapses? And is it known that any viral infection has a negative effect on MS symptoms?
Yeah, very good question. I mean, the whole debate, I mean, I work a lot with animal models. We work on an animal model for MS called EAE. And in that model, there is some evidence that infections, not with SARS-CoV-2, but with other pathogens, precipitate relapses or precipitate the induction of disease. And what I was trying to explain is what they do is they activate these innate cells that drive the T cells that are damaging. So there's a theoretical risk that getting infection might, you know, reactivate a relapse. I mean, and there is some evidence of you know, increased levels of infection with certain herpes virus, with Epstein-Barr virus, and certain bacteria in MS patients. But the evidence is circumstantial, and really we don't have a good answer to that question.
Thank you. So we have had a few queries in this week in relation to the reopening of schools, and staff who work in schools concerned about the risk in school compared to being in other public spaces. Is there anything that you would have to say on that?
Yeah, well, I mean, the first thing to say is that children can get infected, but if you looked at those curves in the graphs that I showed on one of the early slides, you'll see that the numbers of children that get, you know, that are hospitalized is very, very small. So the children get much less severe disease than adults, and therefore they're infected for a shorter period of time. Therefore, they transmit for a shorter period of time. And so the risks to children themselves is pretty low, and the risks of them transmitting it is real, but it's shorter than it is for an adult. I think for primary school children, the risks are much, much less than it is for adolescents in secondary school. I don't think there's no risk, but it's a lesser risk than going to a supermarket, or no less risk than going to a supermarket or going to a restaurant or a pub.
Great, thank you. We have another question in here. So it's regarding vaccinations. Do you consider MS patients to be part of the vulnerable group who should be vaccinated first?
I mean, I won't make the decision on that, and I'm not a doctor, so I have to be careful how I answer this. I don't know what way the NHS are thinking on, sorry, the HSE are thinking on this, so I don't know the answer, but my understanding is that, and this is not based on Irish data, is that the healthcare workers would be the first in line to be vaccinated, and then all vulnerable groups And as to whether the multiple sclerosis patients would be included in that, I couldn't tell you. You know, that's something that really the authority, the healthcare authorities and the healthcare professionals here would have to answer.
Okay. And would you have any comment on the effect of vitamin D supplementation on the likelihood of somebody living with MS suffering from COVID-19 and its severity?
Yeah, we did. I was involved in some work on vitamin D in St. Vincent's a couple of years back. And there is some evidence that vitamin D is beneficial and against MS. And you know, that's circumstantial evidence that people living in northern countries have more severe disease than those living in Mediterranean countries because of the sunlight and vitamin D. So there is something about it, and the good thing about vitamin D, it's a very safe form of supplementation. It's not a drug; it's really a supplementation which could augment the natural response to the natural regulatory response to the damaging response that causes the damage in MS. As to whether it's beneficial in COVID, I think there is a group looking at this. Roseanne Kenny here in Trinity is doing some work with her Tilda elderly cohort to look at this, but I haven't seen any data yet. So I don't know is the answer of the COVID-19, but certainly there's no harm. Certainly vitamin D is a very safe supplementation, that's what I'd say. And there was a question there on the safety of vaccines. I just saw it popping up and I just answered it. Will the vaccine be safe? Well, you know, there's one thing sure, the regulatory agencies are not going to license a vaccine that's not safe. Because this vaccine potentially has to go into the whole population. And, you know, they're simply not going to put on the market a vaccine that has not been stringently tested and shown to be safe. So I would hope that it will get the same level of scrutiny that every vaccine that's been put on the market. There are vaccines that have had side effects. And so I'm not saying they're immune to side effects. So there are, you know, we had an issue with the pandemic influenza and narcolepsy a few years back. And that was in a number of adolescents got narcolepsy. So that happened as a result of vaccination. And there were other issues with whole cell pertussis many years ago. And that vaccine was replaced. And the same way the pandemic vaccine was taken off the market. So there are you know, safety measures that are put in place, but I think we can rest assured that the regulatory agencies have the interests of the whole population at heart when they're testing these vaccines and deciding whether they're safe to go into general use.
Wonderful. So thank you. I'm just going to take actually just one or two more questions, just being mindful of time this evening. So we have another one in here asking, if a person with MS gets infected with COVID-19, should he or she continue with their interferon medication? So I imagine that's going to be a medical question, a question for their own healthcare team.
Yeah, it is a question for your medical consultant, but as I pointed out in my slides, and this is just giving you scientific facts, there's no medical evidence that I'm aware of to suggest that interferon would be detrimental in COVID-19. In fact, it's the opposite. Interferon therapy is being used as a potential treatment, as an inhaled therapy for COVID-19 on the basis of the fact that interferon has both antiviral properties and anti-inflammatory properties.
Okay, that's wonderful. Well, Professor Mills, thank you so much for your time this evening. Thank you so much for your wonderful presentation and for answering questions from our community. Any of them that we haven't got to, I will try to respond to offline, and we'll try to go back through and get answers. And we'd just like to thank you so much for your time this afternoon or this evening, and it's been fantastic for our community, and thank you.
No problem. Thanks very much for everybody for listening.